quick introductions while we're at it. Walking to the stage is Dr. Pragya Shukla, and she is a distinguished medical professional. She has 26 plus years of experience in medicine, including over 15 years of specializing in medical oncology and hematology. She currently serves as the Senior Director of Cancer Care Oncology, focusing on breast cancer, gynecology, gynecological oncology, thoracic oncology, and medical oncology. Additionally, she holds the position as head of the Department of Medical Oncology at Delhi State Cancer Institute. I'm going to request everybody to please sit down. I know you're buzzing with, the last session, but please do, give our dignitaries on stage some airtime. Dr. Ratna? Ma'am, please have a seat.
May we request everyone to please settle down. We're ready to start the next panel.
All right. Can I please have your attention? Or do I have to do a little Mark Anthony and say, ladies and gentlemen, lend me your ears? All right. So I want to introduce our second distinguished chair for this session. This is Ranjit Preetham Kaur, and she's a dedicated patient advocate and breast cancer survivor since 1998. She's been at the forefront of cancer support, patient safety, and healthcare access across the Asia-Pacific region and, of course, beyond. She holds leadership and advisory roles in multiple global and regional organizations, including Asia-Pacific Patient Safety Advisory Board, Reach to Recovery International, Asia-Pacific Oncology Alliance, and the Patient Advocacy Working Group of the European Society for Medical Oncology. As the technical lead on the Community and Patient Access for City Cancer Challenge in Greater Petaling, Malaysia, and the Reach to Recovery Program Director at the National Cancer Society, Malaysia, she actively works to improve patient-centered cancer care. Phew, that's a lot of wonderful work for both our chairs here. Thank you so much for joining us. What about our panelists, Clarinda?
Yes, we have a wonderful set of panelists joining them. May I welcome those of them who are here right now. Dr. Suman Kharakwal, Dr. Suman Karant, Dr. Seema Pai, and Dr. Urvashi Prasad. Welcome on stage.
Round of applause for our chair and panelists, please. Chairs, introduce your colleagues at the panel and take it away.
Good afternoon. We have Dr. Suman Karant with us. So, Dr. Suman, would you like to introduce yourself?
Good afternoon, everyone. Thank you all for having me here, and thank you to my chairs. So, I am Dr. Suman Karant. I am a senior consultant in the Department of Medical Oncology. So, I'm a medical oncologist, and I've subspecialized in gynae medical oncology. I've started my journey very long back, and I've done my MBBS and MD from KMC Manipal. I've went on to super specialize in medical oncology. I've done my DNB medical oncology. I've done my MRCP from London, and I've subspecialized in gynae medical oncology from Christie, UK. And I'm happy to be here today to give my inputs on how we can actually, help cancer patients and how we can actually improve the support for cancer care. Thank you.
So it's a pleasure to have an all-women panel and co-chair and chair here on the eve of Women's Day. So
we are ushering Women's Day. We are ushering Women's Day on the last panel of this day. And I think what Dr. Ratna and her team have done is more or less planned it to make sure that the last session is to usher in Women's Day for tomorrow. It just happened. Right. Yes.
And two women co-hosts. Sorry, I had to butt in there.
Yes, and give a big hand to the team that has organized the whole thing. All right, and it's not always that I am, as a person with lived experience of a non-communicable disease, surrounded by 4 doctors. Today I'm going to give them a hard time. Take it out on my other doctors, so I give it to them. So actually we are looking at what it is like, changing lifestyles, environment changes, all kinds of things that have been happening for those of us who've been around for many, many years. If we look back at time, you can see that there have been a lot of differences that have taken place, diseases that are new environmental changes that have taken place, industrialization from being agricultural countries. We have become, many of us have become industrialized nations, and also at the same time, we have innovative therapies that are coming up, new medicines that are coming up. Healthcare is becoming not cheap, all right? And we are looking at also at issues to do with patient centricity. To what extent is the patient's role important enough to be in this sphere, or is it just the role of the doctors? So now, some of the questions that we're going to ask is, if you all can answer, there's already been one introduction, but we can ask questions like, if you could talk a little bit about what have you seen in terms of lifestyle changes that have contributed, or even environmental factors that have contributed to the rise in cancer, because this is the area that we're going to talk about today. So if each one of you could just talk a little bit about that in your own experience as well.
Should I
At
start?
the
Yes, you
same
can start.
time, also please introduce yourself when you start with the
Yeah, for
topic.
those who have not introduced, you can introduce yourself. Yeah, go ahead.
Yeah, so I think lifestyle has played a very significant role. We know a lot of cancers are related to lifestyle. For example, smoking. Smoking is probably, and tobacco. It's tobacco consumption in any form. It doesn't have to be smoking per se. You chew tobacco, or tobacco paste, any form of tobacco. Hookahs have become, something cool. Everybody does hookah now. Vaping. We don't even know whether vaping is connected to cancer or not, but we would know that in the future. I think smoking has become a very something that it's picked up significantly in the last few years, especially in the younger community, where and a lot of times excuses are given as it's the stress of the job and we need to relieve our stress. Sometimes it is the peer pressure. Because your peers are smoking. So nonetheless, the consumption of tobacco has gone up significantly, and we know it contributes to most of the cancers. Secondly, obesity. I think we are not taking the stairs. We are using the lifts, wherever it is. We are not actually looking after our health. There is no physical exercise happening. We do know that obesity contributes significantly to a lot of cancers as well. And I think Dr. Pragya had actually a beautiful list of things of how we have actually, which she showed me earlier.
I'll be sharing.
She will share it also. We don't eat clean. We prefer to, eat ultra-processed food. We know ultra-processed food has significantly contributed to the uprise of colorectal malignancies in the younger population. So I think this is some of it. Of course, my other panelists will add on to it. But these are I think, some of the 3 top reasons of cancer increasing as of today.
So can we move on?
The next
move on to
panelist,
Dr.
please.
Seema Pai?
Okay.
Hi everyone. First of all, thank you for having me here. I thank Pear, I thank Dr. Ratna, thank my panel chairs here. So I'm Seema Pai. I am not from the oncology side of the treating side, but definitely I'm from the industry. So I work as a senior director for Pfizer. So I look after in the India cluster and the sub-Saharan and African clusters for Pfizer. So my main job basically is in the diagnostic part of it and the research part of it, where we do clinical trials for NCEs, new clinical chemical entities, which are there. And as a background, yes, I do come from an oncopath background, and I have studied in India itself, not gone outside, but at Tata Memorial as an alumnus.
I'm from TMH too.
Yeah, so that's my background. But interestingly, I have moved from the treating side onto the industry so that we can discover more molecules in order for us to treat patients better. Now, I also wear the hat of being the General Secretary for the Indian Society for Clinical Research, and now I'm the President-elect. From the next month, I will be the President. And also active contributor and a very passionate patient, advocate, I would say, from the fact that I'm a patient myself. So that is what makes me very, very passionate and wearing all hats, right from being an investigator in my early days and now a researcher is really something that I take pride. And today, to the question which you asked earlier, I think apart from the lifestyle points which Dr. Suman highlighted, a lot of us, especially the people who are younger in the society, the kind of food habits, the kind of lifestyles they lead is something which one has to really be conscious about, which has led to so many cancers erupting much, much earlier than what we would see them in the past. Also, another area which I think has developed very, very rapidly is the diagnostics, because of which we are able to catch them earlier on as compared to what it used to be about 20, 25 years ago, when most people were not really knowing what is it that they are suffering from. The diagnosis was really very difficult, and the fact that the targeted therapies have come about, people are still not able to understand what is the way in which we can target these, because they first of all don't even know what is the baseline, and they just come about it in a very, very late stage, especially in India and the African countries, the Asian countries, the Southeast Asian countries, and the diagnosis happens really very late. So like what Dr. Suman was highlighting, I think it's the lifestyle which is the keystone, why we are having the detection rates which are happening so early and so many. So with that, I'll not speak too much. Hand over to you.
Thank you. And Dr. Urvashi Prasad.
Thank you. So, by way of introduction, well, I wear 3 different hats. One, I'm a public health professional by training. I've also worked in policy at the highest levels. I was with Niti Aayog for 8 years, where I worked on pretty much all the major health initiatives of the government. And I'm myself somebody living with cancer, which I don't know how many of you in the room would have even heard of. It's called ALK positive lung cancer. So other than the doctors, I don't know how many people would have even heard of it. But surprisingly, the numbers of something like this are going up. And I have a very interesting profile, which many other people with my type of cancer now have, where we really don't know what we could have done better or differently in our lifestyle. Because we are non-smokers. I was diagnosed when I was just 35. I've always been very health conscious, very active, non-drinker as well. And here is where I think the pollution, the contamination, we've spoken a lot about preventable life factors, but if I'm breathing in 1600 AQI, I don't know if I can really control that. And I think it's a real travesty that in the national capital of the country, we are breathing in poison. I don't think anybody here is any longer a non-smoker. Children are born pretty much as smokers because of what we are breathing in. So I don't know, we don't have conclusive evidence to say that my cancer is caused by this, but I think the more evidence we get and the more we are speaking to doctors, it is becoming clear that pollution, contamination in our air, in our water, in our food, a lot of things which we don't even know about, what we are eating, there's plastics in our food. So I think we need to really tackle this. And as a public health professional, these are all public goods, right? Being able to breathe clean air is a public good. It's a right that everybody has. So I advocate very, very strongly for this, because I think it's very unfair when somebody like me gets cancer when we did pretty much everything we could have done right, and we don't even have a family history or any genetic, element of these kind of things. So I think that is the other set of issues that we really need to highlight.
So very well spoken, all the panelists. So when I was going through the agenda yesterday night, I came upon a line. It was about climatic change and cancer and communicable disease. So I had to, that time I was like taken aback. Why is this thing there at all in the agenda? Communicable disease, how come cancer and communicable disease? Why climate change? Although I am a person who strongly believes that cancer prevention and environment control and climate control go hand in hand. We cannot prevent cancer without controlling the damage that we are giving to our climate right now and environment right now. Climate change is no longer just an environmental issue. It is a public health crisis. Rising air pollution, exposure to toxins, and UV radiation contribute to the increasing burden of lung, skin, and gastrointestinal cancers. Extreme weather events and food and water contamination lead to higher exposure to carcinogens. Studies show that prolonged exposure to airborne pollutants and industrial chemicals can lead to DNA damage and an increased risk of cancer. As healthcare professionals, we must advocate for policy changes, cleaner environments, and early detection programs to mitigate these risks. Now coming to the aspect of communicable diseases and cancer, a preventable yet overlooked aspect. Many people are unaware that certain infections directly increase cancer risk. HPV causes over 90% of cervical cancers, while hepatitis B and C infections are leading causes of liver cancer. Helicobacter pylori infection is linked to stomach cancer, and even Epstein-Barr virus plays a major role in the causation of nasopharyngeal cancers and some lymphomas. The good news is HPV vaccines can eliminate most cervical cancer cases. Hepatitis B vaccination reduces risk of liver cancer. Public awareness and accessible screening are essential to controlling these risks. My question every time is, we did it for COVID. Why can't we do it for cervical cancer? Why can't the cervical cancer vaccine be propagated and promoted the way we did the COVID vaccine? We have shown the world we can do it, and hence we should do it again. While I was thinking, I did not read anything per se for this, whatever you call it, a panel discussion or a CME. I was just thinking and I jotted down some things like, what was the thing that is causing these shifts towards cancer in our population? And my pen couldn't stop writing. So the shifts were from basics to modern. Shifts were from using seasonal local vegetable to exotic and round-the-year available vegetables. Shift is from using coarse fiber-rich food to fine food. Shift is from kitchen to cafe and Zomato. We don't cook it anymore, we swiggy it, as my son calls it. We have switched from color to white. At the risk of being called a racist, I want to tell you that we have switched from a colored food to completely a white food. We want to take maida, we want to take sugar, we want to take, I will not, that's little controversial, we want to take milk. We have shifted from circadian rhythm to a happening nightlife. We have shifted from sunlight to artificial white bright light. We have shifted from pure filtered water to RO water. We have shifted from fresh food to refrigerated food. We have shifted from pans to cans. We now use canned foods. We have shifted from diyas to candles and crackers. We have shifted from plant-based fabrics and cotton to plastics. We have shifted from tired means of communication to wireless means of communication. We have shifted from caring for mental peace to building our portfolio. We have shifted from raw to refined and processed food. We have shifted from organic fertilizers to chemical fertilizers, insecticide and pesticide. Hence, we can sum up the shifts that we are seeing in our health as well. So this is, in a summary, I've tried to put all the shifts that are responsible for the shifts that we are seeing in the cancer scenario of the world. And one of the studies of Apollo has quoted as India being the capital of cancer in the world now. So we have to really pull up our socks and do something, do some serious thinking and do some serious work to prevent the major catastrophe that is coming. So can we go proceed with the next question?
Yeah, I think basically what has just been mentioned is that we've shifted from local to global. We've moved from a localized lifestyle to a globalized lifestyle. There are some good points in being global, but there are some very, very bad points that has just been shared with everyone. Now, the thing is, the issue of what we are looking at is the rising cancer cases that we have. A lot has been said about diseases like breast cancer, cervical cancer, but nobody talks about the other cancers. So I was wondering that whether I could start with Urvashi and just ask you the question about what policies are there in place for the other cancers. What are the various perspectives when it comes to prevention, when it comes to treatment, when it comes to the new innovative therapies? Are they affordable by the layman? What about people who are underserved populations? Are they able to access all this? So over to you, Urvashi.
Thank you. That's a big question, but I'll try to quickly, touch upon some key points. So one, I think clearly, as you said, even diagnosing some of these other cancers is not straightforward. I went through a whole process of being diagnosed as having stomach cancer, given 6 months to live. Then I finally had my, the lab to which my sample was sent had the foresight to check for ALK. That, here's a young person, non-smoker, adenocarcinoma, let me check for ALK. Now, I always think if she did not check for ALK, I don't know what would have happened, right? So if this is happening with me, somebody, I would say, who comes from high amount of privilege compared to the majority of the country's population, and not just privilege, awareness, education, all of that. So then you can imagine, what would be happening to others. And that is why I hesitate to call these rare cancers, because we don't even know the accurate numbers in India. Cancer is not a notifiable disease also in most parts of the country. So do we even know? Are we even fully measuring before we can say something is rare or not so rare? A recent study just been released by some doctors at AIIMS where they've profiled young people with lung cancer, and majority are non-smokers, 40% are women. These are statistics and data that we need to really put before the policymakers. I think there is a dearth of that from India. When we had the huge, air pollution crisis, which we have in Delhi year after year, winter comes, it happens, then, we kind of forget about it, then it comes again. And I was really encouraging, all the doctors, the oncologists, if they can come together and make this statement that, look, this is really causing havoc. Only then I think governments will sit up, because governments otherwise tend to say that we don't have evidence. Recently an answer was submitted by the minister in parliament where he said we don't have evidence to link air pollution to any disease. So it's only the doctors, the oncologists who can collectively counter that. So that's one thing I think from a policy making point of view we need. The other, like you mentioned, the treatment. Yes, my cancer, because you don't get any symptoms, there's no screening, so it was diagnosed straight away at stage 4, which is true for 90% of these types of cancers, that they're diagnosed at very advanced stages. So I do have targeted therapies that I can take, but again, very expensive, right? And the public health insurance schemes, Ayushman Bharat, doesn't even cover the first generation of ALK inhibitors, which is crizotinib. Even that is not covered. They are covering some age-old chemotherapy.
So they are covering just the chemotherapy
exactly.
part, not the immuno.
Exactly.
Part.
Yeah. And then private health insurance has a lot of challenges wherein they don't understand that what type of cancer is this, what type of treatment is this. You are not admitted in hospital. You're just having these oral pills. So I think there's a huge gap in terms of treatment, financing. I think we need to do more indigenous research. I always say this, that we have clinical trials for ALK happening in Singapore. Why not in India? Singapore is such a small population compared to India. And India, we don't have anything going on, to that extent. So I think we need to focus on all these dimensions, but it will start when the medical community really rings the alarm bells that, look, this is a big issue, and you can't just say that lung cancer equals smokers, because we're a whole bunch of non-smokers who are sitting with this disease.
So I've been connected to Urvashi through Twitter. So we have been friends on Twitter, and it's my pleasure to tell you all that we are meeting in person for the first time. So I have really admired the way she has been advocating for, in spite of being a patient herself, she has really hats off to people like her. And we had one more person who sadly is not with us anymore. So they really do a lot on the forum. I think not Diwali, last year I wanted to share that I had stroke, so I couldn't do much in the last year. Before that, on Diwali, I had made a video, and I told it's not only lung cancer that is being caused by this pollution. It is irrespective of, invariably, all the cancers are some way or the other associated with the pollution, with the pollutants that we are breathing in. And sadly, it's the climate, it's the temperature that, that precipitates and it becomes visible at that part of the year. But it's there all round. If you go, even now, if you pass Anand Vihar, the sky changes. It's it's different. Today I was reading Twitter and I saw that even Mumbai is having the same. Right now the scenario is the same. They are not able to see the skyline because of the pollution. So where are we heading? We are inhaling carcinogens, we are drinking carcinogens, we are eating carcinogens, and we are living carcinogens in the form of stress. So we are bound to have an increase in the incidence of cancer.
So maybe I could go... Maybe I could go to the next question when we come to that. I was thinking of issues like personalized treatment for patients, innovative therapies. These are buzzwords that are being used all the time when you go for conferences and they discuss it. To us patients, what is personalized treatment may be different from what the doctor is thinking of. So maybe if you could explain in your perspective about personalized treatment and innovative therapies, if there are innovative therapies and they're not affordable, whom are they made for? And why are millions of dollars being used for them, but it cannot reach the people who need them most? Because, I mean, on the one hand, you have clinical trials. On the other hand, you have, clinical trials are over, we have this success rate, and now it's going to be doled out. But on the other hand, you have the issue of, will it be reaching the people who really need them most? How do low and middle income countries, how is it that, how can they be practically used by low and middle income countries? So over to all three of you.
So, just to add on, just before I answer this question, just to add on to Dr. Urvashi's, what she said was really significant. When she said that, clinical trials have to have representation of Indian population. So there are a lot of stakeholders here as well, maybe not from the commercial side, but from the medical side. So we have been advocating more and more that clinical trials do come more and more into India, and we have Dr. Seema here as well, who runs a lot of clinical trials as well. But let me tell you, yes, there is more and more representation of India happening in all the clinical trials. I work with two other medical oncologists. We are a team, Dr. Nitesh Rohatgi and Dr. Ankur Behel, and myself. We are three oncologists, and we do advocate a lot for research and clinical trials. One of the ways where, these targeted and these personalized and these innovative therapies that can be made available to our population is, one, it is through clinical trials. You get the advantage of using these drugs on your patients upfront before it is actually there in the market, and it is free of cost. And obviously, when it comes to this level, it is usually a phase 3 study, so the safety has already been established. So the benefit of that drug can be utilized. So we, as a community, as an oncology community across the country, should probably, work as unison and say, what, we have this clinical trial at our center. So if you have any patient who you would wish to, benefit from this therapy, please send this patient to us. And only if we work together, we can actually have healthcare systems like what is available outside in a high-income country. We have a lot of innovative therapies and a lot of targeted therapies, and the cost is high, as Dr. Urvashi mentioned. Ma'am mentioned that, the cost is high. There is always a cost for technology. We understand that. There is always a patency. When a drug is made, there's a lot of clinical research happening. There's a lot of scientific backing, investments, technology happening. So it cannot come at a price which is low. But we have to understand we are in a country, we have the strongest pharmaceuticals. A lot of targeted therapies that were available some time ago are now multiplied as called, what we have as biosimilars, which are much more affordable to patients. And we know that our pharmaceuticals are strong, so we know the drugs do work. And while we may not have the current therapy that probably is just released a year ago, like immunotherapies, they are still patented. But what you should understand is the government is trying to help patients. They do have a patient assistance programs where, we do try to help for the indicated, for the approved indications, that we give some sort of financial comfort for the patients. It is still high, I do agree. And as it was rightly mentioned, the Ayushman Bharat, it's just 5 lakhs. So where are we even going to talk about immunotherapy with 5 lakhs? But nonetheless, as the patents actually expire, more and more generics will come, the price of these innovative therapies will actually come down.
I'll take a shot from where Dr. Suman left. So first and foremost, we have to understand the number of trials that are being done in our country for the population that we are. Like, we are still at about 1.4% of the global clinical trials that are run. Only that percentage is run in India, which is really a very sad story, because as ma'am said, until and unless there are more trials that come and there is an experience for the oncologist to look at the patient journey when the trials are ongoing, it is very difficult for any person to have faith in the drug once the drug is then launched after many, many years in India. So that's the first thing. So that is a collective exercise which has to happen, and that is not happening because of some of the regulatory pathways which are there at the present moment. And of course, it has changed significantly from what it was in 2017, and we have come a long way after the NDCT rules have been released. And then we have gone a little mile further, I would say. We are yet not there. So just from a statistical point of view, India does just a minuscule number, which is as compared to what even a small country like Taiwan or Malaysia does in terms of indigenous research. Now, when we say indigenous research, one part of it is the global clinical trials, which can give the experience. The other part is what we could do from the medical fraternity within the country, and those drugs which are already there, those drugs can be really tried off by the Indian oncologists within the country for us to make the research environment better. While there is work which is being done by the BIRAC, by the government of India to develop several aims, several oncology institutions in India, there is a network which is being built, but it is a slow process. By the time we reach there, we may lose out on all these targeted therapies and the precision medicines that we are talking about. And to the other question which you asked, Ranjitji, was on why is it that we are having such a costly rate card here in India as opposed to what we see in the other countries. Definitely one is the price control which is there, and for the price control there are many newer drugs which have come under price control, which is a great win for many of the patients in India. And slowly and steadily there is an awareness that some of these need to be included by the government at a rebated rate. I don't want to discount the fact that many of the companies do run the patient assistance program. They try to negotiate, I can tell you from the other side, a lot with their principals to get a rate which is an India specific, India friendly rate. And it is always about economics, basically. How can we, make it more India friendly? We try to even change the brand name. What you see globally will not be the same name that you see in India. Why is that? That is because we try to negotiate, saying that using this, we will be able to protect the patent in India, and we will be able to get it at a cost which is a little lesser and affordable for our Indian population. So there is work which definitely is done. But yeah, whether is it enough? Maybe it is not. There is a lot of work which has to be done, partnering with other stakeholders as well.
Urvashi, your point of view, please.
So I would just say that, we need to look at solutions that we can do now, and then, of course, also medium, longer term, because a lot of people, we frankly might not be around by the time we have cracked this if we keep waiting for that ideal day to come. So I push the government a lot on these things, that people like us can't afford to wait. For us, urgency, time, every day matters. And so India has huge numbers, right? That's what our strength is our numbers. And that is what, as a government, if we can really put forward as an offer, whether it's to a pharma company, whether it's to somebody doing a clinical trial, that, we have so many people to offer to you, right? As patients, as people who can use your drug, or people who can be on your trial. So that is our strength. And we have to be able to now use that and say that this is why you should come here, and we will help you get through the regulatory process. We'll help you get through the challenges, because a lot of regulatory kind of bottlenecks also happen. With clinical trials, what happened is that many years back in India, we had a couple of very bad incidents. And as governments often do, we then kind of went on the other extreme of regulating trials. We've pulled back a bit now, but we went to the absolute other side, where we made it almost impossible for people to come and conduct trials. And also what is important is that a lot of the innovative work might not always happen in a big pharma company. It could be a smaller life sciences company, for instance. And they find it almost impossible to navigate our system here. It's so complex. So I think government also has a huge role to play in attracting, the best of external research to the country. But also, I think, lastly, I would say on this, that our investment in R&D is way too low. It's abysmally low. And public sector as well as private sector. If you look at a lot of the developed countries, it's very private sector led investment in R&D, but not in India, So we really need to step that up, because people can't keep waiting for a drug to come off patent, or, 5 years later for a trial to come. They're gone by then, they're not here by then. So we need to start doing things here and now, and we have huge aspirations for the country. And we will not get there if we don't start, immediately.
I just want to add, just one point to that. What she said was really important. The drug development. Yeah, drug development. I think we need to get more and more phase 1 trials and, preclinical trials as well. I think that's where we are lacking. We don't have actually drug development. I think you would also be able to tell us that. And this is what we're trying to get, so that, if we develop the drug here, we can obviously get the prices down. But if somebody else is developing the drug elsewhere, it's always going to be at their price.
It's happening, no, now
so
we
it
have
is
the
happening
cancer
now.
vaccine at a
So we have the,
CAR T
CAR-T
cells,
cell
yeah.
example, where there has been a clear public health collaboration with IIT, with the Tata Memorial, and with a private agency. So all three coming together and doing it. But that is one of a kind. It is not always.
So here
and
I
if
would
there
like
can be, ma'am, just one point there would be that if the drug discoveries in India can be really translated, because there is a sheer lack of translational research work that is happening in India. We had the best indigenous laboratories when there was Ranbaxy at one point in time, but then the rest is history, So the point here is there are very few innovative drug companies doing oncology core research in India, and we do have a Dr. Reddy's doing a little bit of research. But to get what is done, discovered outside, and then bringing it into India, it's like pushing a mountain for somebody in a pharmaceutical company any, Indian arm of a pharmaceutical company, it's very difficult. So the quick wins here, certainly, as ma'am said, we can't wait forever. So what we are trying to do is get in the cycle times for the phase 3s, the phase 2s faster. When I mean cycle time, I mean the time we can get the approval, the number of patients, because patients are our strength, and also the quality of data. What is important is not just the speed, but it is the quality and the completeness of the data. We have seen examples where within India, while after all the regulations kind of settle down, we still see that the oncologists really are not concentrating on things like overall survival, the progression of disease, the tracking and tracing of patients. We are such a vast country. Patients in this country, I mean, not the privileged ones, even if we are doing a targeted therapy, they don't understand that we have to come back to the centers, we have to do the overall survival follow-up, and it is till the end of their life. And this is something which is a thing that most pharmaceutical companies are looking for. Unfortunately, that data is, patient thinks that I have got cured, and loss to follow-up is something which is a very significant problem in our country. And pathways to trace the loss to follow-up, pathways to look at how can we do better with overall survival. The education to the oncologists is very, very important. And what we see is, maybe 20, 25 years back, when we were studying, it was a different story. People were wanting to do clinical research because the ecosystem was there in the hospitals to really get trained and to do clinical research. Today, it is really a very sad story, because we aren't getting the medical graduates to actually have the rigor to do it. Even though everything has become very electronic, they would rather leave it to their coordinators or the clinical research unit in the hospitals to do it, which is the unfortunate shift that we are seeing at this moment in time. So we are trying to educate, we are trying to advocate, going to every center, explaining the newer therapies and what is to be done. But yeah, that's where we stand.
So coming from a government setup, I had a institute which gives every molecule free of cost. So we are not giving immunotherapy, we are not giving the latest targeted therapy. So one thing that I keep fighting for is, till we get the recommended treatment to the poorest of the poor, we are not winning this fight against cancer. So the dearth is not, that I've said again and again, I keep reiterating that the dearth is not of funds, the dearth is of intent. So we have lot of CSR activities, lot of government funds who are ready to, chip in when the patient needs. Why are you giving free of cost drugs to people who can afford? We have to have a Robin Hood approach for this cancer treatment at least. People are coming up with luxury cars and they are taking all the treatment free of cost. And people who really need targeted therapy, immunotherapy, and cannot afford are not being given that. One of the very good pharmaceutical company, I believe people from that company are sitting here as well. They went out of their way to give us the loading dose of a particular research molecule free of cost to us. We were not able to give the maintenance doses to the patient because of bottlenecks. So why are people becoming custodian of the exchequer? We are nobody to, be the custodian of the exchequer. The money, the taxpayers' money is for medicines, is for education. The thing is that we should have the wisdom, the intellect to choose who should be given free of cost, who should be charged. Like we had in Tata Memorial, even the doctors consultants did not have any say in declaring a patient free of charge, free of cost patient. It was the social workers who were deputed there, and they used to decide independently which patient has to be given the treatment free of cost and which patient has to be charged. So please don't involve the doctors in it. Let them be free for only treatment so that they do not bow down to any pressures from people of power to give the treatment free to people who can afford. This is one thing that I have been harping at all the podiums. I hope somebody listens to me sometime. And then coming from a government setup, I say that the onus lies on us. We have the numbers. Why can't we get the data? Why can't we give the drugs, like companies can give us the drugs so that we generate data? This data is a gold mine that we can give. Why can't the government take up, go in front, volunteer to, generate the data? I know we are overworked. I'm also coming from that same setup. When I was appointed, 3 people of my rank should have been there, and we were appointed for 200 patients. Now we are seeing 100,000 patients plus, and I'm still alone. So I know we are overworked, but there are ways of doing it. We have people like, no, I've seen people giving us helping hands. We have NGOs, we have manpower assistance that is being provided by pharmaceuticals. We have software assistance that is being provided by them. So we can do the work in a better and a very, structured way. So things are like, no, it's very easy to say it's not affordable. It cannot be, it's a patented drug. We cannot give it to a patient. Why? You have to find ways. There has to be an intent to give, not an intent to reject. Who are we, gods? To decide whose life is how important or how not important. Somebody's life may be saved with 50 paisa. Somebody's will be costing 50 lakh rupees. So how can you decide that 50 paisa wala is worth it and 50 lakh wala is not worth it? So I am very passionate about it that the recommended treatment should be affordable to the poorest of the poor, should be available to the poorest of. Now we have to find out ways and means of doing it. I know the exchequer has some limitations, but we don't have limitations in finding ways and means. We are a jugaad country. We have to find ways of doing it. Why can't we do it? I'm sure you'll be having certain ways of putting the things for. You wanted to put in something, Suman? You were saying something?
No, I'm agreeing with you absolutely.
So this is something which I'm very passionate about. So we cannot give to the people because the cost. I fought for the EDL of Delhi, that why we are not having immunotherapy in it, why we are not having targeted therapy in it. So sadly, couldn't convince the people who are at power. So we need more people, more advocates, more strong voices, and probably more celebrities to join in. Celebrities is something like, all the celebrities and Bollywood is hell-bent upon showing cancer is not curable. As soon as a cancer diagnosis is made, a sad music will come in the background. And you will start seeing patients with dark. Can you see Urvashi? She's look glowing.
And
we have patients like this.
And only US doctors can fix them.
And US doctors can only. Fala went to UK, theek ho gaya. Fala went to America, theek ho gaya. Fala went to somebody in India, did not get cured. So this is a very big misconception that is being. Gone are the days of Anand movie. We are not in that era anymore. Our patients are as pretty and as glowing as Urvashi. You can see that. And they have a strong voice and they are our celebrities now. Please give them the celebrity status. They deserve the celebrity status. Not the person who are saying Zawa Kesri. You know?
It looks exactly like I'm sitting in Malaysia. And we don't get very many doctors who speak like this. You have to be outspoken. Because we as patient advocates, we can only speak a little bit and the people in power will not listen to us. We need people in power to listen to be listened to. It's people in power. The oncologists who are at power, they should be able to speak up for patients. Because if the patient does well, so does the oncologist, because then they feel that I've saved my patient.
So I always tell my patients the happiest person on this earth is going to be your oncologist when they declare you treated and cured.
Yes.
You know, for us, a normal report is something which is very special. Yesterday, I went to my children's ward and then they made me realize, a special day is one when the report is normal. All days which are normal are special and need to be celebrated.
Yeah, I think, ma'am, that's absolutely right. I mean, to just add on to ma'am's point, when we go to see a PET scan and we see that there's a progression, we are actually more stressed than the family. I know the patient is stressed too, but you have to understand we are also stressed because we want our patients to do well. And the whole time we are thinking, oh my God, what should we do next? What should we do next? Because we know there is kharcha. How do we break the bad news? At some point of time, I think people forget that, the doctors are actually...
So ESMO, the European Society of Medical Oncology has come up, Suman, I want to take this forward, has come up with a program in which they are addressing the grief and the, the sadness that the doctors are going, oncologists are going through. I always tell my patient, your family has one patient. My family is made up of patients. So you imagine the grief and the pain that I go through. So never think that your doctors are not feeling that pain. We are feeling the same pain. Every patient is special for us. It's not the one who comes out from BMW or who has got a phone call from the CM office is special. No. Every patient who comes to my desk is special, is my family.
So Dr. Pragya, to bring you back to that perspective, Yours is the doctor's perspective. Ours is when we are walking into the doctor's room, we look at the doctor's face to see whether it is good news or bad news from the scan. All right? And while we are walking in, we are looking at the face, whether the doctor is going to say, everything is fine, or the doctor is sitting like this, so we know that something is wrong, right? So the thing is, there's a lot of communication going on without words, and I think communication is very important. And when it comes to communication, I think the previous panel spoke a little bit about that, when they said, what are the questions a patient is going to ask when they are first diagnosed? We are blank when we are told we have the disease. We don't know what to ask. We don't know how to ask. We have got a dry mouth. We are panicking. We are in a state of shock. All right? Health literacy does not come straight away from the patient when they are first diagnosed. Health literacy, I think every doctor should know what are the general questions that a patient is going to ask. I'm now turn it over to all of us, all of you, to give us a little bit of perspective on health literacy, on understanding, because mind you, I come from a paramedical background, but when I was told a few things, many of the terminologies were new to me. I didn't understand at all. So over to you about health literacy.
Whenever a patient comes to the first consult, everyone's shocked. So I don't push the patient, I don't overload them with information. We have prepared patient information sheets. Yet again, we decide whom to distribute it. Everybody doesn't want to be overwhelmed with that information. So again, you have to choose, you have to understand the psychology of the patient. Maybe upfront, they don't want to know everything. So I always talk to them the basic thing, and I send them home. I ask them to come back at another date. I take another appointment, write down all your questions, and ask me. So they are always there with a paper with 10 questions, and I patiently give them time. I never call them at the busy point. I usually call them in the afternoon, and I just sit with them and I talk to them. And I say, okay, tell me all your questions. Or when they have come for chemotherapy, they have their list, and they're ticking, and they're asking me questions. So it is, you have to understand, not all patients want to know everything. Some patients want to know everything. Not everybody wants to hold their reins of control of their treatment. Sometimes they just say, Doc Sahab, aap hi karo. Some people want to decide everything. So for us also, it takes time, not the first visit. I won't identify all these qualities on my patient. It also takes me time to identify which patient, how much should I speak, how should I handle my patient. So it takes time for the doctor as well. So sometimes when patients feel, oh, she was so blunt, or he was so blunt, or the doctor didn't have any time, please understand, we also are, it's a journey, it's a patient and doctor journey as well. Information, I would always say, please ask your doctor. And doctors, will give you facts. This is where the patient advocates are so important, because they are going to break down these hardcore facts and make them more realistic, make them more understandable for the patients. So I think this is where we as doctors need to sit with patient advocates, talk to each other, and then the patient advocates are the ones who are going to be the bridge between the doctors and the patients. And every patient is not comfortable asking the doctors questions. I think they are more comfortable asking the patient advocates questions. So it is very important to identify which patient wants to know what information. And please don't ask the neighbors. That's my only thing to all the patients. I always say, if you have a doubt, don't ask your neighbor, don't ask your relative, don't ask your other, because there are 200, Dr. Google, because there are 200 different types of cancers. One treatment may be just chemotherapy, other chemotherapy may not work. So you can't come to me and say कि उसको तो targeted दिया, उसको तो 4 cycle दिया, मुझे तो 10 क्यों दिया, उसको तो tablet दे दिया. Everything is different. So I only say you come to me 10 times, that's okay, but just don't ask your neighbor for any advice.
So even the theme for this year is United by Unique, right? So each cancer is different, each patient is different, each treatment is different. Each treatment has different side effects in different patients, so each patient that way is different. Each treatment has response to the same drugs different in different patients, so that way is also a patient is different. So please, honor your uniqueness, honor your unique personality, your body. Don't link it with the treatment response and side effects of any other patient. Yeah, Dr. Seema, you would like to?
Yeah, I would like to give a different perspective, mainly from, when she asked about health literacy, right? It's about how we as companies look at health literacy. And the thing is, I will share, company-wide view. We in India get a lot of materials which are all created in the name of health literacy, which are like patient-facing materials, which come in from a global view or a global lens. Many of it is things which we don't even think in India will be of use. Things like a tote bag coming into India. People don't even know what is a tote bag. Why are you sending and why are you wasting my time importing all this into India? Instead of that, they also have things like thank you cards, which are all in English, which have got the figurines of what is a totally westernized outlook. So what we have done for most companies as a society, as what we advocate is, just don't use these. We create India-specific materials talking to our patients in India through our patient advocacy groups when we are creating and we are running these protocols so that it becomes India relevant. We don't use all these fancy type of materials that is sent, and we become literate to our patients the way they understand it rather than it being something totally westernized. And the examples of this are like, we get questionnaires which are like in e-format, and then we are expecting our patients will use Google phone, they will use Samsung, and they will start to scroll through it, and they will be totally understanding what is the mechanism of action of targeted therapy, or they will understand what are the symptoms they will undergo. Now, a lot of this we have tried to customize, we have tried to make sure that it is in the translated languages, we have tried to use figurines which are not westernized, they look Indian. So a lot of customization is what we are working on, and making sure that the Indian patient voice is also incorporated in those materials that we are receiving, so that we don't waste time on, all this. So yeah. Rishi?
So, I mean, I have obviously my own experience on this as well. So I, went from 31st March 2022, I was absolutely fine, right? I was sitting in a meeting with the then Chief Minister of Chhattisgarh. I traveled to Raipur. I was absolutely fine. I went from there to just under 2 months later getting this diagnosis. And I did not even register what on earth this was. I remember my first meeting with Dr. Rohatgi, who happens to be my doctor. It is a complete blur. I didn't know who he was. I didn't know what the hell was being said to me. And I just remember one sentence which he said, oh, I have a patient who's been on this targeted drug for 7 years. And that just stuck with me. And I was like, 7 years? I'm only 35. That's not good enough, right? And that's what I also say, that stage 4 needs a lot more. The moment you get a stage 4 diagnosis, it's almost like be grateful for what you've got. But I'm sorry, I'm 35. 7 years is your good case study? Well, that's terrible. And so I went into severe depression. I'm sitting in front of you today. There's no way on earth I would have done that in 2022. People were speaking to me. I couldn't reply to them. I was eating food. I couldn't taste what I was eating. Prolific writer. I couldn't write one word on my laptop. So that was my condition. And I had to finally one day say to him, he even sent me to a counselor, didn't work for me. I was like, I don't know what this lady is talking about. And so I had to tell him that, look, I'm going to kill myself before the cancer kills me. So can we do something about this? And that is when he put me onto an antidepressant. And I actually say that as much as I value my cancer drug, I probably value my antidepressant more, because it allows me to be sitting in front of you like this and to be having some quality in my life, which I would absolutely not if that was not the case. So I think every patient is too unique in how they would react. I mean, I was so far from asking any questions. Probably now, 2-3 years later, I'm able to ask questions. There was no question. I was just in so much shock that questions was like a far cry for me. And therefore, I just advocate very, very strongly that sometimes an oncologist can't do everything. You know, you expect the oncologist to also be a mental health specialist, to also be palliative care specialist. I mean, oncologists are already very hard pressed for what they're doing. And therefore, you need a care team. You know, you need people who can look at a patient when they walk into the room when first diagnosed that, okay, this person is in serious shock. There's a blank look in their eyes, and we need to do something about that, right? So you need that trained, qualified person. Similarly, on palliative, in India, we understand palliative as end of life. That's not the case, right? It is also end of life, but palliative has to start from the day you start your treatment because you have side effects. You know, I had a lot of gastrointestinal side effects or other side effects. So palliation starts right from there. And we need these specialists in an oncology care team. It cannot all be the onus of the oncologist because they might just come across a patient like me who they just don't know, you know, what do we do? There are other patients who are very like with it, you know, they just go there, they ask the oncologist, okay, what's my prognosis, I was not one of those, you know, I was in complete and utter shock that my life had just been blown apart. So I think we need to have specialists who are trained to handle each type. Like Dr. Pragya said, each one is unique. There's no one size fits all. And we'll all react very, very uniquely given our situations.
Thank you, Urvashi, for sharing. I think Dr. Pragya and I are like very busy talking here. We didn't even bother to see whether the audience is still around. Are there any questions? We have just a couple of minutes left, but we have many hands. I have to ask Ratna permission as to how many can we take. Okay, right in front here. A mic. I think we'll just take a few questions at one go, and then we'll see who can take some of the answer them. All right, go ahead, please.
Well, I just want to add to everything you wonderful women talked about. By the way, I was diagnosed with this stage 4 vocal cord cancer before 27 years, and I was given few days to live with. Since 2011, that is for 15 years, I am into patient advocacy, and trust me, wherever I meet, I profoundly mention that you don't need to go outside India for getting your treatment done for cancer for 2 reasons. Number one, the oncologists in India are truly human beings. They are not your enemy. So trust them to the core. And one more point I would like to add here, because of my advocacy, I am having a privilege of having acquaintances with more than 500 oncologists across India, irrespective of any cancer hospitals within Mumbai, Delhi, Lucknow, anywhere. So it's all about, you know, our real blood, our real passion, our real empathy the oncologists in India are having. So I salute all dedication and your contribution to the cause. Thank you so much.
Thank you. A big hand to all the oncologists. All right, over there. Yes.
I'm really sorry to cut this off, but she's given us strict instructions that we have to close this right now because there is another meeting at 5 and we need her to come on stage to just...
I just want to say, patients don't die before you actually die. Cancer is not a death sentence, so there are a lot of treatments, so please just remember that.
Yeah. Okay, can we just have a little round to end up everything? Maybe we can start with Urvashi. Who do you think can be the stakeholders, the entire group of stakeholders for prevention and treatment of cancer?
Yeah, I think, you know, obviously, I would say patients have to be at the heart of whatever we are doing, whether it's trials, whether it's the actual treatment. of course, even prevention and screening, much more upfront. So patients, people obviously have to be at the heart of it. But then around them, clearly the doctors, obviously, and that's why I said doctors can be a very powerful voice on a lot of these issues, especially if they speak collectively, to policymakers, then I think that could make a big difference. Government, of course, has a huge role to play, especially on screening. I feel that we need to do a far better job, screening, early detection. And now we also need to look at, what do we do with this rising cancers like lung cancer where we don't have any screening, right? So even people who are non-smokers, at least in our big cities, can we do something for them where we are breathing in, absolute pollution every single day? So screening, I think government and of course treatment also, insurance need to do much better, service deliveries need to do much better. Government has announced cancer care centers at the district hospital level, but my worry is always that, we need to have the qualified personnel, we need to have enough medicines there, diagnostics. It's one thing to announce, but it's quite another thing to operationalize. So that is there. Then, of course, the private sector, I think our pharma companies, people who are involved with the research side, we really need to push for research, more indigenous research, more affordable research for people. So I think they're also obviously a huge stakeholder. And I think, just people at large, right? I would just say that cancer is no longer about just that if it affects me, I'll talk about it. Because you just never know when it might affect somebody or your loved one or you. So don't leave it for that, let somebody else talk about it. I think if we can all at least talk about it, talk about prevention, screening, detection, then I think it can make a difference. So I think I would say each one of us is really a stakeholder in this.
Thank you, Urvashi. Seema, would you like to add anything else that Urvashi has just mentioned?
No, I think mental strength and hope is something which every individual should carry, and clinical trials give hope. Most importantly, it is not something which is a stigma. That is something which every one of us should spread, because that's the only way in which we will be able to gain trust from our stakeholders. So that's the only thing I would like to add to what Dr. Urvashi said.
Patients are the heart of everything. Without the patients, we do not exist.
Thank you.
It's the patient.
And with that, we would like to conclude by saying there's no medicine like hope, H-O-P-E. No incentive so great and no tonic so powerful as the expectation of something better tomorrow. That's what we want. Clinical trials, patient-reported outcomes, and also patient experience outcomes as well. So this is by Orison Sweat Marden. Thank you, everyone, on behalf of Dr. Pragya and myself and the team here of the panel for doing such a great job. Thank you.
All right, thank you so much, panelists, Dr. Pragya, Ranjit, Dr. Suman, Dr. Seema, and Dr. Urvashi. Thank you so much for that very heartfelt session. And a round of applause for our panelists.